Next up, we have the ever-inspiring Dr. Chitra ma'am, who will unveil intraoperative wisdom in her talk, Anterior Chamber of Secrets.
Thank you again. So let me try to be as crisp and brief in this very important talk about intraoperative pearls in premium IOL implantation. So the whole day we've been talking about how premium you get into doing a cataract surgery, but when we do premium, we are not just get pricey with our patients, but we have to raise the bar for ourselves, which becomes mandatory that we do look into the pre-op planning, the diagnostics, the way we do our phacoemulsification technique to ensure that the visual system accepts the IOL which you have promised these patients. The incision is very critical, be it a uniplanar or a biplanar or a triplanar incision, because this incision is what is going to define the stability of the fluidics in the eye and allow a smooth cataract surgery. It's limbal, but I prefer to make it near limbal to just get that little ooze, which will get a proper vacuum seal. I would like to ensure when I make my incision that the roof and the floor are of equal thickness, and also that the inner lip, that is, I create a trapezoidal incision, the inner lip is little larger than the outer lip. We already know that when we talk of surgical induced astigmatism, what we have understood today, which was told to you earlier on in the talks, was a 2.4 millimeter incision or less induces a centroid value of just 0.1 or 0.12, and if the if the incision is 2.8, it might induce about 0.3, and that all is need to be considered. So then going further, we also know that when we talk about doing a premium IOL insertion, it is about effective lens position. That is where the intraocular lens sits in the bag. And the latest formula and technology has helped us to place the IOL right in the bag with the right capsule ram. But what has become confounding is that we've also understood through different studies that there is a change in the anterior chamber shift by 17.6% within 1 hour to 2 months of over 1 millimeter. So although you have used the best of formulae to ensure the lens sits in a particular position in the bag, it actually does not. So you are not able to exactly nail it. So what can we do intraoperatively? You can get a perfect rhexis. You could ensure that there's proper rhexis overlap. You should ensure that your nucleotomy does not cause too much zonular stress so that the capsular bag architecture remains the same, and do a complete cortex and viscoelastic wash. So how I would prefer to do is to use my RK marker to get that 5 millimeter rhexis. Here I'm gone to the main port, but ideally I would like to go to the side port so that the main port is closed, the anterior chamber does not shallow at all, and thus you are not getting a rhexis runoff and get that complete round rhexis. Now the importance of getting that ideal rhexis overlap is, in case the rhexis is larger, there is an optic capture, the intraocular lens will come forward, it could be a tilt, and astigmatism is induced, or you could even have a myopic shift. So then the other way is to use a Varion overlay during the surgery, a digital overlay, which keeps coming on so that you could ideally define your rhexis to come within, inside, and complete the rhexis adequately. You could do it on a femtocataract platform, which is largely the scanned capsule mode, wherein the machine scans the anterior capsule and the posterior capsule, and also extrapolates the information of the theoretical equator of the capsular bag, so that the lens anyway sits in the equator of the capsular bag. So this brings in greater accuracy. And on a catalyst platform, this rhexis can be done within 1 second. And also you could even do it centered on the pupil, which is called the pupil maximized mode, or a custom sizing of rhexis, which is done in a subluxated cataract, to ensure that you get this kind of consistency in your cataract surgery. Now this was a case of an intumescent cataract wherein the rhexis is small, but it is adequate to go ahead with my regular phacoemulsification techniques, which has happened quite comfortably. But then the rhexis is small, there could be phimosis and back contracture. So you should not leave your rhexis like this, but go into the side port, make a tangential nick on the rhexis, and enlarge the rhexis and round it off so that you get that 0.5 millimeter rhexis overlap and a stable intraocular lens in the back. Now again, it is very important as intraoperal that you do a good hydrodissection as was shown to get that fluid wave and ensure that after decompressing you rotate the nucleus adequately to loosen all the cortex. One is when you do your phacoemulsification, you're not stressing the zonules because the nucleus is quite mobile, and also the entire cortex will come out at one go. This is again, I'm going to be a little rapid in my steps here. I would like to make one small trench when I start my cataract surgery, but then once I have grip of the IOL, it is essentially the fluidics of the eye. There is no ultrasound energy being used, and you have to use the safe chopping techniques, which is eminently possible. You can have an intraocular pressure of 40 or 30, a stable anterior chamber without a flutter, and go on chopping and do a complete cataract removal. I'm not going to show you this case. And now again, it's a small pupil here. So if you're on a femtocataract platform, you could create your grooves, you could create your grid pattern, you could even size what is going to be the size of the grid, which would be more on if the density of the cataract is more. You have the latest software where you can even skip repeated pulses, that is called skip repetitions, can be done so that the whole laser passage and getting the grid patterns and grooves happens in a fast manner. And then, in spite of the fact it's a small pupil, you don't even have to use pupil expansion devices, and you can do a very smooth, eventful cataract surgery and complete the case. Now, you could also, like you know, in a prelex, if you are doing a routine phacoemulsification, you might find that you're cheese wiring the lens and you're not able to get a proper grip at times. But if you're on a catalyst platform, it actually creates you the grooves and the sextants or the quadrants which you want. And once all of it is done, here you can see that there is a 4 quadrants which is created, and you're just bunching up the capsular rexes as is being shown, and you can do an inside-out hydrodelineation as I show, then the grooves just separate, and you can see these individual pie are just lying as if they have to be just taken off, and this is how easy the surgical procedure becomes, and now the intraoperal for getting a good surgery done. Again, the cortex removal was beautifully shown by all those live surgeons, how you could just do a hydro polish and remove those few lens epithelial fibers and get it washed off. And as far as the trifocal centration, we all know there is an optical center, a pupil center, and a visual axis center. And it is important that all 3 of these dots are well aligned. Angle alpha is the distance between the optical center and the visual axis, and ideally an angle alpha of less than 0.5 would be ideal for the premium IOL implantation. And in fact, all the concentric rings would be centered around the pupil, and this is how the IOL should be ideally placed. But what advantage we have with the modern IOLs is they have a larger central optic. So even if the angle alpha is more than 0.5, even if it is 0.8, if it's a panoptic, symphony, or synergy, you could still go ahead and implant a premium IOL. When it comes to toric axis alignment, again, you could use a slit lamp to make that thin beam to mark the 3 o'clock and 6 o'clock positions as is being shown here. You could use an ASICO marker, wherein you make the patient sit upright to cancel out the cyclorotation, and then use the ASICO marker to mark the 3 o'clock, 6 o'clock, and 9 o'clock positions. You could use your manual marker, like supposing you do not have access to the digital overlays, you can mark on the slit lamp the 3 o'clock and the 9 o'clock, and then on the table to recheck, place the Mendelssohn's marker to reconfirm that those marks are right. And once you have reconfirmed, you could place your toric axis marker to mark the axis of placement. And then only thing, the conjunctiva should be not too wet, the marking area should be pinpoint, and the marking should be done properly. Again, if you're on a proper Varion axis overlay, so once you have injected viscoelastic and you have injected the intraocular lens, the only point pearl you need to remember is that the IOL should be about 10 degrees off axis so that you can remove it. Now, if the IOL is too off axis, in the process of rotation, you could weaken the zonules and you could even create a PCR, and you need to remove the viscoelastic in front and back so that these could cause a toric IOL rotation later and align it finally on the axis. Again, hydroimplantation was beautifully shown, wherein you increase the IOP to 90 millimeters, keep the infusion on, inject the IOL into the capsular bag because the capsular bag is AC is quite deep, and then bring down the IOP back to your 30 and then dial the IOL inside. You also have this marker, that arc which you see here, wherein after removing of the viscoelastic and aligning the IOL on the axis, you carefully look at the ball. When the ball would come to the center, which is further indicative that it's on axis. So this again, there are on the Catalyst platform those intrastromal incisions or the toric markers which are now available, which makes this whole step so much more precise than the manual markings which are possible. And this is a small astigmatism of 0.858, but when you're doing a premium IOL surgery on a Catalyst platform, you have the ability to make these small arcuate marks, which are based on Donenfeld's nomogram, Nichamin's nomogram, which tells you exactly what is the length of the arc and what is the degrees and what is the optic zone where you have to locate these arcs. And after cataract, before the surgery itself, I open up these arcs. This is the older video where these arcs have been removed after performance of the cataract surgery. And then there is, I would just like to show you one surgical situation. Now, this was a case of a polar cataract. And then there has been a horizontal PCR. So just adequate vitrectomy is done. So this is a case where we have promised a premium IOL to these patients, but there's enough of capsule above and below. So what I'm going to do is inject the toric IOL into the capsular bag, ensure that the haptics are in that place where the PC is intact. And once I've positioned it properly on the axis, what I'm going to do is get the optic up and out of the bag, because there's a central PCR. You can't possibly leave the intraocular lens in the capsular bag. So once I do a reverse optic capture, the haptic is well aligned in the capsular bag. And these, as you can see, this is how the optic has been brought forward and is well aligned with the capsular bag. And you can see it's on axis. And this is one way of being premium, even if you've had a PCR. And see, 3 months post-op, also this patient is doing well. This is the post-op refraction. Now, this is the last video I'm going to show you. This is a case of a PPC cataract, and a PC blowout is already there. So I'm doing a mechanical delamination so that there cannot be any hydrodelamination. There is a blowout of here. Uneventful cataract surgery has happened. I'm able to even remove the cortex because although there's a PCR, the vitreous phase is intact. I inject tricor to see there is no vitreous. I actually convert that small PCR into a PCC and then place the IOL in the capsular bag, and it's a toric IOL and it is well aligned. So basically, I would like to conclude that there are these stringent intraoperative pearls which we need to look carefully right from the incision to the last part, or even if you've had a complication, to ensure that you get premium with these premium IOLs. Thank you very much.